Okay, that was a great panel that we just had, and we're now going to launch into, we've cascaded from the beginning to this moment. In this session, what we're going to be trying to do is give you some of the tools necessary by describing and showing how some of the most effective efforts to address clinician well-being during COVID-19 have occurred. And we want to emphasize in this, and that will be emphasized by the nature of the panel, interprofessional and intraprofessional efforts. What are some of the barriers? Some of the facilitators, and what are some of the things that produce a conducive environment for change? In order to do all that, I'd like to introduce to you our next moderator, who has more initials behind her name, I think, than anybody else in the panel. She is, again, quite an extraordinary person, and I will only highlight some pieces of her biography. Pam Cipriano is the Sadie Heath Cabaniss, I hope I pronounced that right, professor of nursing and dean of the University of Virginia School of Nursing, immediate past president of the American Nurses Association, and the current first vice president of the International Council of Nurses. She has been named a top thing at least twice. In 2018, she was one of the top 100 most influential people in healthcare, voted by Modern Healthcare, and that was for the fourth consecutive year. The publication also named her one of the top 25 women in healthcare in 2015. Dr. Cipriano was the 2010-2011 Distinguished Nurse Scholar in Residence at the Institute of Medicine, which is now the National Academy of Medicine. She's been a longtime leader in ANA. She was the inaugural editor-in-chief of the American Nurse Today, the ANA's official journal, and was the recipient of the association's Distinguished Membership Award, inducted into the American Academy of Nursing as a fellow in 1991, and in 2018 received their Healthcare Leader Award for advancing nursing for health policy. She holds a PhD in executive nursing administration. She has been actually highly educated across the United States. You will see this. From the University of Utah College of Nursing. She has a Master of Physiological Nursing from the University of Washington, a Bachelor of Science of Nursing from American University, and a Diploma in Nursing from the Hospital of the University of Pennsylvania. I turn this over to Dr. Cipriano, who will introduce her colleagues, and this will be a really fabulous session, building on everything that we've done, going towards, as Dr. Zal told us from the beginning, action. So Dr. Cipriano.
Thank you so much, Tim. I appreciate it. We have a distinguished panel of colleagues, and I will unfortunately only give you a very abbreviated version of their biographies, and so that we can have you start to hear from them pretty quickly. And I will introduce them to you in the order that they're going to speak. The way our panel is going to work is that we have three presentations, and following each, the panel is going to have some dialogue, and then we'll be following the questions that you send in the chat or the Q&A function, and then we'll have some time at the end to bring all these thoughts together. So our first presenter will be Dr. Bryant Adibe. He's currently the System Vice President and Chief Wellness Officer at Rush University System for Health in Chicago. He also is an offsite full professor of organizational change and leadership at the University of Southern California and a visiting professor in Guangzhou, China. He also has served as the Chief Wellness Officer at Mount St. Mary's University in Los Angeles, where he was instrumental in helping them raise significant funding to construct a state-of-the-art wellness pavilion at that facility. Our next speaker will be Dr. Jonathan Ripp, known to many of you as well, a professor of medicine, medical education, and geriatrics and palliative medicine, Senior Associate Dean for Wellbeing and Resilience, and Chief Wellness Officer at the Icahn School of Medicine at Mount Sinai. Jonathan is well known as a thought leader with not only the NAM, but ACGME and the American College of Physicians. He's also co-founded CHARM, the Collaborative of Healing and Renewal in Medicine, to promote learner and trainee wellness, among many other accomplishments. And our third speaker will be Dr. Anna Legred Dopp, a a pharmacist, currently Director of Clinical Guidelines and Quality Improvement at the American Society for Health System Pharmacists. She brings a rich background, having done a fellowship and then worked directly in health and social policy at the congressional level. She's also held positions at the University of Wisconsin Hospital and Clinics and was an elected officer in the Pharmacy Society of Wisconsin. So we're going to share with you a number of perspectives from the macro and microsystem level and talk about actions that we can take to be implementing systems to solutions to all of the issues that we've been talking about preventing and stopping burnout, as well as promoting strategies for well-being. I will turn it over to Bryant.
All right. Well, thank you so much, Pam, and thank you to everyone for really the privilege to be able to present to you all today. In our session, we really will look at this question of well-being through a few different lenses, from what I like to describe as the world beyond our walls, and then getting increasingly more granular. And so on that, I'd love for us to get started. So the first thing I'd like to ask for all of us as participants and as people is that we take a deep breath as we think about this year 2020 and all that it has entailed. So just a deep breath in and out. We know that 2020 has been a pivotal year for our national consciousness around mental health and well-being. We know that never before has supporting our neighbors as well as caring for ourselves been more important. And never before have we had really a greater catalyst for change. Next slide, please. When we think about the early surge, we know that our health systems have faced unprecedented challenges and have been forced to adapt and demonstrate an agility that many felt was impossible. Next slide, please. And while we pass through a meaningful, albeit short-lived heroism phase, we know that as we enter a second wave, many are suffering from exhaustion, COVID fatigue, burnout, and depression. Next slide. And next slide. On top of that, we faced a historic global economic crisis, the worst that the world economy has seen since the Great Depression. Next slide. Families have struggled for bare necessities, and we've seen a widening of the inequality gap, with those higher wage workers who were able to work remotely faring relatively well, and those who were maybe already on the line, already struggling, continuing to suffer. Next slide, please. 2020 has also been a pivotal year in our national discourse regarding social justice, equity, and racism. Conversations regarding police brutality, human rights, and the plight of Black America has entered our consciousness in ways that are reminiscent of the civil rights era. We know that riots followed months of isolation and civil discord, months of lockdown. Next slide, please. On top of that, this is an election year, one in which political pressures have added a heightened sense of anxiety, stress, and others as the world continues to watch and wonders how we'll respond. Next slide, please. So it's undeniable. This is
well, maybe while we're waiting for him to get back as well. Again, one of the clear messages that Brian wants to send is really framing the fact that, as you've read in publications that our leaders of the collaborative, Dr. Zhao, Nazca, and Kirch, put forward in our peer publication about multiple pandemics, there are so many converging forces right now, even beyond what we saw with COVID, on top of the original concern about the epidemic of burnout. And so framing these issues as really being additive to the stress that everyone in the country is feeling, but more intensely, what healthcare practitioners have really been experiencing with no outlet in sight, or be having to continue to come to work day after day, or to even in areas where we think the pandemic has eased a little bit, where systems have been experiencing a less than anticipated onslaught of patients. We know that the financial issues are there, the racial disparity issues are there, the additional stress, as was just in his slide of election stress, is there. So wanting to be able to put this into context and recognize that this is really a time that we have to double our efforts and really take seriously the solutions that need to be put in place at a systems level. So maybe
Pam, I am back.
Oh, good. Okay. That's good to hear. I don't see your picture up yet. But why don't you just go ahead? Because you should be able to
Great.
continue with your slides, right?
Well, thank you. And
Oh,
listen,
there you are.
Yep, I think Zoom chose the perfect cliffhanger time to cut out there, but we'll pick up from where we were.
Great.
So next slide, please. So as I was just speaking about, and I really appreciate you, Pam, stepping in there, I mentioned about this idea that health systems do not exist in isolation. And one such way to understand this is what's known as the ecological systems model, which was developed by Bronfenbrenner in the 1970s, at first to really describe early human development and childhood development, but has since been applied to organizational science and organizational change. It helps relate the individual's relationship with their community and with the broader society. And it can really be broken out into 5 key environmental systems. The first is the macrosystem, which relates to really the individual and the immediate surrounding of that individual. And then there's the mesosystem, which we can think of in this context as being the health system, so the major work settings and other environments. The exosystem, which speaks to some of the social structures and some of the other dynamics. And then the macrosystem, which we know incorporates things like culture and also some of the national and international challenges that we faced. And one of the latter systems that was added to this was the chronos system, which really looks at changes as they relate to time. It's chronos. Next slide, please. This slide, in many ways, I think, summarizes a lot of what we were just describing. And if you hit next one more time for me. There we go. You'll see that hospitals and health systems really exist at the center of a convergence of a number of different stressors, a number of different factors, all of which contribute to the challenges that a health system faces. Those challenges out at the macro level, at the exo level, and also at the micro level are really the combination of factors that influence our community, that influence our culture, and that influence the reality of the world as it exists within our walls. Next slide, please. Next slide, please. There we go. So one of the second takeaways from our talk is simply that these pressures, whether we realize them or not, whether we accept them or not, shape in a very meaningful and impactful way our institutional culture. And in many ways really have a very driving force on the realities that exist within our walls. And so while we may not realize it, some would say it's almost irresponsible not to acknowledge or recognize the role that these forces play in the lives of both our patients, our employees, and meaningful members of our community. Next slide. So what role should healthcare play in that broader world that exists beyond our walls? That's something for us to consider. Next slide. In my mind, as we think about really the future of healthcare, there are 3 key areas that play a really pivotal way in answering that question as far as what role we should play. Next slide. And those 3 areas are leadership, partnerships, and values. Certainly topics that have been addressed so far through this great NAM Action Collaborative. Next slide. On the leadership side, I really think one of the keys is understanding and re-envisioning health systems not as simply servicers of a given community or as providing a really meaningful and valuable health service to the areas that we serve, but also really as becoming active, engaged participants. What I like to think of as the Anchor Plus institution, not just an anchor institution, but plus in the sense that we are defining and creating that future as we see it. Next slide. This is really one of our points of pride here at Rush. We have what we call our anchor mission, and which is a whole commitment to the Westside of Chicago. And beyond these meaningful programs, such as our Westside Walk for Wellness, we also have a whole strategy around economic investment in our supply chain, in educational pipelines, and in employee development for residents of the Westside. From our perspective, what's good for business is good for Chicago and is ultimately good for the communities that we serve. Next slide. As we look to the future and think about some of the harsh realities that we face, we recognize that health systems will have to form and develop strategic partnerships in order to really address these 21st century problems. These include public-private partnerships, as well as cross-institutional partnerships. I mentioned earlier and really described this talk as the world that exists beyond our walls. But I would like to posit that as we look to the future, increasingly, we will have to bring those walls down. If there's any lesson we have learned as health system leaders during this COVID-19 pandemic, it has been the speed of information outside of our institutions. So if our crosstown competitor happens to roll out a certain initiative for their staff, asymptomatic testing, other initiatives, within hours, we know about it here and ultimately are forced to respond. And it's that sense of cross-institutional collaboration that really will define us going forward. Next slide. One of the ways that we've done this here at Rush is with really a meaningful investment in what's known as our Center for Clinical Wellness, which is actually the space that I'm speaking to you from. This has been a multi-year heavy investment that we have placed on a space that has a number of technological innovations and support here in downtown Chicago, including the use of what's known as an optimal healing environment, the tones and texture, some of the great work of Wayne Jonas and his team out of California to incorporate the outside within and to provide a space where healthcare workers could get outside of the hospital environment, rest, recharge, and improve their well-being. Next slide. We use this space as a really a hub for our public-private partnerships. So in the photo on the left, you see a photo of myself and Chicago Mayor Lori Lightfoot. And I'm actually demonstrating one of the technological innovations, a 3D sunroof that moves like the sun, casts a shadow like the sun, and ultimately replicates a bright, sunny blue day during those deep, dark months of winter here in Chicago to improve and provide the psychological benefit to our healthcare workforce. We use this also as an opportunity to work with the mayor's office to co-develop a strategy for improving the well-being of the Chicago community, leveraging the academic expertise of the Rush University Medical Center with the mayor's team's public policy prowess to be able to really find a joint way forward for improving and helping our city. On the right there, you see one of our really more popular amenities, our energy pod, which our healthcare workforce has really taken advantage of. Next slide. Finally, in conclusion, I would like to end with really what I like to think of as our third and final piece on this foray into the future of healthcare. And one of those is a common conversation point that I'll often hear from colleagues both within and outside of the institution, which is, what are we going to do about this issue of wellness? What are we going to do about this issue of respect? What are we going to do about this issue of equity? And the reality is, wellness is not an issue, it's a value. Equity is not a problem to be served in the moment, to be solved in the moment. It's a value to be demonstrated through our day-to-day work and through the commitments that we make in our institutions and in the way that we model that with how we serve our communities. Next slide. Part of how we demonstrated our values here at Rush is by really hosting a series of open-ended mental health forums. And I should say for the attorneys and others on the line that this photo was taken pre-COVID. This was taken pre-pandemic. We hosted a series of conversations in which we brought the topics, the taboo topics of mental health, of suicide, of mental health crises, and of the challenges that healthcare workers face into a number of different forums. And this one pictured for our students, but also for our nurses, for our docs. I hosted these at 3 o'clock in the morning for those that were here overnight, late at night at 10 for those in our second shift. And we had over 1,000 members of our community come together to talk about what many had considered to be a difficult subject to breach, as well as to provide training on what they can anticipate going forward. Next slide, please. So finally, as I said in conclusion, wellness is a value. It's not an issue. It's not a problem for us to solve momentarily. It's something for us to demonstrate. As we think about the future of healthcare and really the impact of wellness, we know that there's no greater place to have a need for a focus on leadership, on partnerships, and in demonstrating our values than in clinician well-being. We know that from almost half of the states in our country, there's physicians are still required to declare if they seek mental health care from a provider. We know that we're losing, on average, a physician a day to suicide. And yet it's these external forces, these policy forces that exert undue stigma and pressure on the well-being of the clinicians that we serve on the day-to-day. And from my standpoint, I think that's wrong. So as I look to the future of healthcare, I believe in a future in which those who need help can get it quickly, consistently, and without fear of stigma. I believe in a future of healthcare where the concepts of self-care and wellness aren't something new or different or unique. They are the norm. And finally, I believe in a future of healthcare where we welcome students, residents, and trainees into a culture of respect, kindness, and equity. So on that note, I'd like to open up to our distinguished panel with our first question going to Pam. So Pam, as we think about some of these broader societal challenges and how we see them impacting our staff, what are some of the issues that you see reflected within your own institution or without? And what are some of the opportunities for growth for us as we look to the future? And I'll just add next slide.
Probably the most pressing issue that I see that I know is not unique to our environment is the desire to really make an impact on the social determinants of health. I think as the COVID crisis has demonstrated the disproportionate effect of COVID on particularly people of color, not only the infection rates, but the death rates. And as the country began to grapple with all of the social justice issues. And for myself, being in Charlottesville, Virginia, where we have spent the last 2 years really trying to address, educate, and be much more forthcoming around the legacy of slavery and those kinds of issues, it all really converged and became another internal crisis time, which is what are we doing? Particularly many of our physicians and nurses and other professionals said, we can't just ignore that this is another pressing issue as we think about taking care of patients. And maybe we can't create yet another program or really focus on so many of the things that will be necessary to have a much more structured program that really looks at the most egregious health disparities, but it's something we have to be cognizant of and make the commitment now to do everything that we can as we work through the pandemic, but also as we come out of this on the other side and really can capitalize on the fact that we've brought together data, we've brought together our social scientists, we are in dialogue with the members of our community, but we have a much higher level of commitment to do something about that, recognizing that we can't go through this kind of situation again without addressing the upstream issues of all the socioeconomic differences of the historic suppression and oppression of people of color.
Absolutely. I'm going to John next. Now, John, listen, in this pandemic, your team, and certainly your institutions showed incredible leadership, as New York went through this early surge. What were some of those broader challenges as you saw them as related to your institution?
Yeah, I think the challenges that we experienced were not necessarily unique in terms of those that the rest of us are experiencing. It may simply be that by virtue of being in New York, we were in the geographic space that kind of, at least for the U.S., of course, was experiencing it perhaps first, and in obviously a really sort of accelerated way with the surge that we saw back in March and April. So I think the challenges are what we're all experiencing when facing the need to essentially transform your healthcare system to a unified goal. And so obviously much of that was around figuring out how to take care of just an enormous amount of patients with this new illness. But then folded in is, how do we take care of our own? There were some really major lessons learned, I think, around thinking about staff support in the context of emergency response. I actually think there are some significant lessons which many of us chief wellness officers are working on putting together. Lessons learned for how to do that when a crisis like this is faced.
Absolutely, thank you. Anna, how would you relate this really with your role as a national entity and certainly the perspectives that you'd be able to share?
Thank you. I want to first start by saying thanks to the National Academies for the opportunity to be on this panel. It really has been such an honor to collaborate with my fellow panel members. And Bryant, you've got us off to a great start. And already you're having me reflect on the framing of this as an issue versus a value, and really taking away from this the need to make sure that these things are woven into the fabric as a value and not just an issue to work through and then check off a list. So thank you for that. I'd also like to commend the exceptional NAM staff for a really impressive event that you've organized and facilitated. No easy task for sure to pull off a meaningful 8th public meeting and to still be able to invoke the feelings that we've been able to share over the last number of years when we have been able to meet in person. I'll share briefly and I'll talk a little bit more about ASHP, the American Society of Health System Pharmacists, in a bit, but we serve as the collective voice of pharmacists that work amongst physicians and nurses and other colleagues in the healthcare environment to help improve medication use across the spectrum of patient care. And we continue to benefit from the collective expertise and the collaborative spirit of this action collaborative, as Dr. Singer said yesterday, and we couldn't agree more that the efforts of this group we truly experience the idea that a rising tide lifts all boats. As it relates to this issue, I again like to thank Bryant for your thoughtful framing of it, and then also to hear the important reflections that we've heard from Pam and John. And you talked about the converging of forces, Pam, and it's so true. You see the headlines, and you see the epidemic within the pandemic, the opioid epidemic within the pandemic, or the twin pandemics, wanting to make sure that we are all getting vaccinated against influenza in anticipation of the influenza season ahead of us, and the infodemic that we're in. And so we really are at some critical intersections. And I'll just speak to the intersection of two emergencies, which are the global pandemic and then the deeply rooted societal unrest that our communities and healthcare teams and healthcare systems have been experiencing and seeing amplified in the last few months. And as you indicated, both of these emergencies have amplified the disparities amongst Black Americans, Hispanics, and other persons of color in our societies. And they're really amplifying the disproportionate burden that's being experienced in terms of higher rates of infection and worse outcomes that is revealing these broader social justice issues. And illuminate the fact that health systems do not exist as islands and are called upon to work on as something within their value system. And so what have we done to respond? I'll share a couple of things, but I'll just start with a caveat to say we have a lot more to do. Every May and June, as part of our annual policy development process, we hold a regional delegate conference and a House of Delegates forum to advance and approve various position statements for our organization. And as you can imagine, this spring and earlier in the summer, we had to do all this virtually because of the pandemic. And the meetings were occurring at the same time as the protests across the cities in our country. And if ever there was a time where being physically together, where we could have harnessed the opportunity to heal and process, it would have been during this time. But virtually, we channeled our concerns and our fears and responded by developing 2 task forces focused on racial diversity, equity, and inclusion. One that's working with our external members, and one looking at internal staff and looking to listen first and then respond. So these task forces are charged with taking inventory of ASHP efforts in areas of racial diversity, equity, inclusion, as they relate to the issues facing Black Americans, and for making recommendations across our governance and committees, such as our boards of directors, commissions, councils, sections, and forums, and then also looking to take action through our various efforts, such as education and training, research, advocacy, publications, and communication. So we anticipate that the work of these task force, which which kicked off late August. We expect to hear recommendations to be shared with our board of directors in January, and then hopefully to take meaningful and sustainable change and action. And then lastly, I'll share that we collaborated with 13 other national pharmacy associations to issue a joint statement taking a stand against racial injustice. In drafting that statement, we followed the lead and the tone that was set by colleagues from the National Pharmaceutical Association, which is a professional pharmacy association that's committed to serving underserved communities and promoting minorities in pharmacy. So from those efforts, we're learning a lot. We're taking stances against marginalization and oppression, and looking to continue the dialogue, some meaningful dialogue. So I'll end by saying it's just a start. We have a lot more to do, but we are committed to listening and then taking steps forward.
Absolutely. Well, thank you, Anna. Pam?
Yeah, so Bryant, you have a poll question. I forgot to tell our audience, we do have a couple poll questions that we want you to participate in throughout the time this afternoon. So if staff would please put up the first polling question. And what you need to do is go ahead and do your answer. We'll give you a brief period of time here to respond. Okay, staff, can you show us the response? Oh, interesting. Okay, so the question was, does your institution view wellness as a value or an issue? So 50-50. Okay. Bryant, any quick response to that?
Look, I think, Pam, it's interesting, and at the same time, it's not. I think up until this point, for many institutions and for many of us, frankly, I think we have seen wellness as an issue, as a problem to be solved, as something that if we just get the right strategy around it and enough smart people in a room, we can solve it. And I think part of our goal today, right, as a panel and as a group, is really to posit this idea that it's a value. And like all values, we have to remain committed to it over time. We have to demonstrate it with the patients that we care for, and we certainly have to model it with our own staff and clinicians.
Right. If you were to speculate, if we had given the option of both, do you think we would have had a significant response that it's both a value but still an issue?
I wouldn't actually. I would say we'd likely have a similar breakdown. I really would. And I think because as we are still early on in this evolution of how we see wellness, I think many institutions, as I mentioned a second ago, are still very much in the issue phase. And I'm hoping certainly with the work that we're doing here today, that we can begin to shape that.
Great. Okay. Thank you. All right. We're going to move on to Jonathan.
Great. Well, thank you so much. It's really a pleasure to be with you today. And Bryant, that was a really great presentation. What I will say is I know one source of my stress in COVID has been all issues related to AV. So I can really sympathize with you there and the cutting out. So let's hope I get through mine without too many challenges. If we could go to the next slide, please. Thanks so much. So I'm going to be chatting with you about the role of the CWO, really the role in general, and then sort of how perhaps the Chief Wellness Officer has participated in response to crisis. And I put these slides together a few days ago, but have really had the benefit of reflecting on this wonderful program that's been underway this last day and a half. I was thinking about Dr. Zhao's comments about how the Action Collaborative has really been championing the Chief Wellness Officer role, and I feel incredibly a great deal of gratitude for the groups highlighting what it is that we can accomplish, and in doing so by making leadership engagement another one of their priorities for the next year and change. I imagine for those of you that are tuning in today, there's probably a varied familiarity with what a Chief Wellness Officer is. I hope to shed some light on that and clarify that for you. and do so perhaps in the context of how a chief wellness officer can be effective in the midst of this crisis. It's really hard to speak about anything that any of us are doing these days without talking about how COVID has impacted our world. Certainly, Dr. Farley, another chief wellness officer who we heard from yesterday, shared what an incredible example Christiana has been in addressing COVID. And I think, though, there's been a varied experience in terms of how health systems and hospitals have experienced COVID to date. There also appears to be, in my view, an emergence of what are some of the best practices in supporting clinicians and supporting a workforce during COVID. And those, I will share in greater depth, but in broad strokes, it's meeting basic daily needs. It's providing some degree of frontline support to the folks in the field who are working. It's robust mental health and psychosocial supports, building on those wonderful presentations we heard earlier this afternoon, often including proactive elements and sometimes peer and buddy support, such as what Dr. Sinsky mentioned yesterday and what can be found in the AMA Steps Forward module. So clearly we've heard a lot about these efforts. I think, and perhaps what some of these best practices are, I think the key thing is, how do you operationalize all that? How do you actually take what you want to do and make it happen in the midst of crisis? And I would contend that a chief wellness officer can really play a pivotal role in that. Many of us in this role have done that in the midst of crisis. So if you could go to the next slide. What I want to draw your attention to is a piece that we recently published, myself and Dr. Tate Shanafelt, who is the Chief Wellness Officer at Stanford. And we put together this piece called The Healthcare Chief Wellness Officer, What the Role Is and What It Is Not. It's actually pretty important to create some confines around what the role is, because well-being can really become everything in many ways. And so, to Bryant's point, if you think about it as an issue, it can encompass, all the challenges of a healthcare system. So it's pretty important to define the confines of the role. What I capture here in distilling from our piece is that, it's about measurement. So the chief wellness officer is the person who can bring expertise about how to measure well-being. A lot of times we talk about burnout, but that's just one tool that we use to measure well-being. There are many, and that's what the chief wellness officer can do. This is a person also who listens and partners to steer the ship. So if you liken the healthcare systems to a large tanker that's underway, that in the ocean, there are huge drivers, the system drivers that we speak of, that are sort of, impacting the course that tanker is taking. Well, it's the job of the chief wellness officer to understand what it is and who it is within the healthcare system that can steer that ship on a course that leads to greater well-being of the workforce. And the chief wellness officer can provide the expert guidance about how to inform those stakeholders who are influencing those system level drivers and help push things in that direction. Clearly, there's a role to be an advocate. I think Brian's point about value versus issue. I mean, our job is to advocate that well-being is a value, that well-being is a strategic priority of a healthcare system, and that it is part and parcel with all of the other values and outcomes of a healthcare system. So we have to educate, raise awareness about that, about all the ways in which well-being has a role, and really, do so in a way that is understood and heard and resonates. So a lot of times that means sort of changing your case a little bit and your narrative, depending on who you might be talking to. And then lastly, I'll say there's some degree of program delivery in terms of rolling out some of those initiatives, but it's really largely about identifying those who can deliver on those system level drivers that impact well-being. So I think if you've seen one chief wellness officer, you've seen one. There kind of is a lot of variability. But if you go to my next slide, what I want to share with you is one model, at least for Mount Sinai. If we can advance. Thank you. So at Mount Sinai, this is our organizational structure. So we sit within the School of Medicine, and as such, there are multiple constituent groups that we direct our efforts within the school. Those are in the resident space, the GME space. Those are in the faculty space, the medical student UME space, the graduate school, and of course, those are just our team. We partner across the health system and the hospital system with hospital level and other healthcare professional leaders to create consistency around well-being efforts and elevating well-being as a value. Certainly, it's critical to have an infrastructure, and this is where I want to speak to how the chief wellness officer can have a role in the midst of crisis, because by having your tentacles out, if you will, in understanding what are the needs of the varying constituents across a healthcare system, that can enable you to gather information about needs and disseminate information about resources in a rapid fashion. And indeed, that's what we did. If you go to the next slide, I want to just spend the next couple minutes talking to you and kind of validating some of what we heard earlier from Dr. McCants about sort of the common stressors, but I want to share with you what it was that we experienced personally here in New York. In the beginning, as we were first starting to see cases unfold, it was all about a fear for meeting basic daily needs. It was, how am I going to get to work safely? Who's going to take care of my kids at home? How am I going to keep myself safe and my loved ones safe when I come home? Where am I going to find the next meal? All of those basic daily needs. As the cases began to ramp up and we saw a near doubling almost on a daily basis, uncertainty settled in as the major source of stress. How am I going to be able to take care of all of these patients? Will I be prepared if I'm redeployed to a place that I haven't yet been working? Are we going to be able to have enough resources for all of our patients? How long is this going to last? Uncertainty set in at that point and really was an incredible source of anxiety. And then as cases began to fall, in May, here in New York City at least, that was a chance for us to process, to grieve. For some, this is when we really started seeing and became increasingly concerned about the psychological consequences. We have also concurrently been measuring this in keeping with that role of the chief wellness officer to measure. And Dr. Sinsky spoke of this yesterday, that the AMA has enabled the measurement of the consequences of the pandemic. We were able to see that nearly 40% of a sample of our workforce across multiple constituent groups were experiencing symptoms of either depression, anxiety, or PTSD. And so we also found that pre-pandemic self-reported burnout was one of the strongest predictors of those consequences, which in our view kind of validates the need to be measuring this stuff on an ongoing basis, because clearly burnout can have a significant role as a contributor to these negative consequences in crisis. So it's important to address that before you get to that point. And then certainly in May and that time, there was the layering on of other external stressors, such as what's been highlighted in this meeting, the role around racial injustice and all that we saw at work and continue to see. So if you go to the next slide, you can see how the chief wellness officer can play a role in addressing those stressors. First of all, just by identifying what the major source of stress is at a given phase in a pandemic, and in rapid order meet those needs. Certainly, we partnered across our health system through a task force that was able to enable the delivery of provision of basic daily resources and information about how to keep yourself safe, and of course the PPE to keep yourself safe. We played an important role in communications. When uncertainty is the major source of stress, providing information and communication is the treatment. And so doing so in a regular, authentic way across multiple platforms, whether it be emails, wellness messages, town halls, websites, that is a critical a critical need that we were able to contribute in the midst of crisis. And then, of course, providing for robust psychosocial mental health resources, picking up on what our earlier speakers spoke about in the beginning of the afternoon, and doing so in a variety of ways, whether it's through virtual support groups, crisis lines, telepsychiatry, what we called a mental health PPE coined by our lead psychiatrist, where we provide a proactive outreach to the folks on the front lines, and then frontline relief akin to what Bryant spoke about. We're having these recharge spaces for people to go to take a break. So the chief wellness officer, by virtue of understanding the lay of the land and having the infrastructure, we were able to really roll that out and respond. I'll make one point before the next slide, and I'm near the end of my time, I know. But I would contend that here and now uncertainty has again reared its head as, and this is not a watershed statement, but has reared its head as an enormous source of stress, because now we're layering on not just resurgence of COVID cases, but external societal stressors and that we don't know what's coming. And so paying attention to uncertainty, providing that information is critical at a time like this. Of course, coupled now with the exhaustion that so many of us are feeling, which is really a tough one to address, because on the one hand, we want to encourage people to take a break, and on another hand, there are other forces at work that are suggesting to people that we need to prepare for what's coming. Really a major challenge to address. If you could go to my next slide, please. So I put this here for you just as an example of one means to share resources. And so this is commonly referred to as an infographic. It's a way of bringing a lot of information in a visually appealing way, and then you can disseminate this. And so this not only gives you an example of how it can be done, but also shows for you the importance of having an array of resources, recognizing that no one size fits all. And certainly, to coin what our behavioral health colleagues here at Mount Sinai say, all of us can use some support in times like these. Some of us will need treatment. And so it's important to provide robust resources in both elements. At the top left there is our Center for Stress, Resilience, and Personal Growth. This is a new center that is one of the durable outcomes of this crisis, in that we now have a means for our entire workforce to provide screening, referral, treatment, and resilience training across our health system. Next slide, please. And so, I'll finish by speaking to the COVID pivot, right? So many of us have been talking about how we need to pivot in the midst of all of this, and how we did pivot. Really, my role was completely transformed. I spoke to kind of what the role of the chief wellness officer is on that first slide. Clearly, we pivoted in the midst of crisis to address shifting priorities that occurred as a result of COVID. Well, we need to keep doing that, and yet now we maybe need to start thinking about pivoting back. How do we pivot back to some of our other priorities? And it's a real challenge, because things are definitely not the same. We talk about the need to address the system, and clearly that is where we've placed the focus, because it's our belief that the system is where we're going to have the greatest impact on addressing well-being. But there's also been an increased need to focus on the individual. So we really it's a fine balance as we begin to pivot back. Certainly, there's an ongoing need to pay attention to the role of uncertainty and anticipatory anxiety. And then as we shift back to systems approaches, we need to think about the role that the impact of the financial implications of this crisis. We may be dealing with a different set of resources to address the efficiency of the workplace. And so it's important to think about what may be some of the lower or even no cost options that can continue to promote systems level change. I think of those being the culture options, particularly thinking about coaching, appreciation, and incorporating the healthcare professional themselves in the improvement process, building on the model from Swenson from so many a few years ago, I should say. And my last slide, if you could go to next, I just want to was asked to draw attention to the multiple layers, the multiple levels, and Bryant spoke to this in reference to the ecological model. This is actually taken from our the CHARM, the Collaborative for Healing and Renewal in Medicine Charter on Physician Wellbeing, which is found in JAMA and on the AMA website. And in it, we speak to commitments at multiple levels. Certainly, we talk about the organizational level, and that's really synonymous with systems approach. And we talk about that being oftentimes where we need to place our focus so that the onus doesn't appear to be on the individual, even though we can't ignore the individual level commitments as well. We owe it to ourselves to pay attention to our own needs and to prioritize self-care. And we've heard a lot about that this morning. So there is some degree of individual level commitment. It's not zero. We do place the focus on the system, but on the other hand, what is the role of societal drivers of well-being? They're playing a huge role right now, as we know, whether we're talking about racial injustice, whether we're talking about the influence of anxiety around elections or the financial climate. And so having an approach that focuses on all of these levels is critical. So, as and I think that's if you go to the next slide, I think that might be it for me. I put this thought question in here. What happens when those factors are largely external to the healthcare system? What is the role of the chief wellness officer? We're going to get to that, I think, a little bit in our discussion, I would hope. But a lot of times, certainly in my initial couple of years, the focus was on our own system. Certainly what COVID has taught us is that sometimes the main drivers of the well-being of your workforce are occurring outside of your place of work. So I want to just say I do try to end on a note of optimism. Optimism is part of the prescription for resilience that my own dean, Dennis Charney, speaks of. It is one of the contributors to resilience. And so what I will say, and I think Josh Morgenstein from the Center for Study of Traumatic Stress, when he talks about how currently many of us have spoken to, we're now in the disillusionment phase of this crisis. I think he also speaks to how the great majority of us will get through this, and not have any kind of long-term consequences. We'll be okay. Some of us will need treatment and will benefit from treatments that have evidence to support them if we encourage people to seek those treatments. But clearly there's an opportunity now for post-traumatic growth. I think the opportunity remains that this will be thought of by many of us as an extremely meaningful time in our career, even though there are enormous stressors. So with that, if you advance, I think that'll serve as a placement slide there to move to our discussion for our panelists. And I'll start by maybe asking you, Bryant, if you could perhaps share an example. And it's the same. I have the same question for all three of the panelists, but perhaps you could share an example of how you were able, and you did already to some extent, but maybe there are more to share, how you were able to leverage your leadership role to quickly develop support for your constituencies in the midst of crisis.
Yeah, absolutely. Thank you, John. And I think part of it started with, so as many institutions had a central command center, right, relative to the pandemic, we really, as I said, have prioritized wellness such that I sat on that command center as a principal. And I think that helped really connect the dots with what was happening relative to the pandemic and how we were rolling out our wellness support. From a contextual standpoint, certainly, John, I think you recognize the challenges that you all faced in New York as the geographic spread of this pandemic evolved. And listen, in Chicago, we were about 2.5 to 3 weeks behind you on the curve, so to speak. And at one point, Cook County, Chicago had the highest rate of COVID cases in the country. And really, when you look at Chicago and kind of zoom in even further, at one point, Rush University Medical Center was treating 1 out of 4, so 25% of all critically ill COVID-19 patients in the entire state. And so that was kind of the context of what was happening around the time that we started to support our staff. And so we knew we needed to rapidly, stand up an infrastructure for our entire health system. So we launched our wellness task force, really as a way to consolidate our own responsiveness and to ensure agility. We developed 4 key strategies. So the first being wellness rounds, the other being our wellness resource hub, which was a central location for folks to get off the unit. We also launched a wellness consult service where we were able to connect directly members of the wellness team with frontline providers. And then finally, we rolled out what we called our Wellness Plus initiative, which was really a collaboration between our wellness office, psychiatry department to provide really support for those rapidly escalating and serious cases. So we developed really a 4-part strategy. John, I know you would probably agree with this. I wish I could tell you that it worked perfectly. And, looking back, we designed it in a way that would perfectly run. And to say that would simply be a lie, right? We identified the needs of our institution in real time, tried to fill those needs, adjusted as we went along, and then really found this strategy to be something that we could roll out. And we put all of that together, really our playbook together in a New England Journal Catalyst piece that goes into that in detail called Creating Wellness in a Pandemic.
Thanks, Bryant. Yeah, I think, for all of us, this was our first, real major pandemic, right? And so, of this scope and magnitude. So clearly, a lot of us dealing with things for the first time. What you mentioned that I'll just reflect on before asking Anna to respond to the same question. But, and also kind of building on that optimistic and the meaningful aspects of the work, Dr. McCann spoke about this in terms of the speed at which something that might ordinarily take months occurred in a single month or and sometimes shorter. The way in which groups across the system came together and, in very short order evaluated the impact of their interventions and then modified as needed if seeing something didn't work was, for me, that kind of experience, even if we weren't getting it right the first time around or the second or third, was enormously meaningful to know that we were, quote unquote, in it together. So that resonated with me. Thank you. Anna, if you could share, and of course, in your previous comments, you shared a lot about what you've been engaged in, but any particular examples from your perspective as it relates to leveraging your leadership role to provide support for groups in the midst of crisis?
Thanks, John. And the COVID pivot, that definitely resonates. We've heard it a lot today. That's the phrase of 2020, along with "you're on mute," I think. But I think that you point out it's really important to stop and think about the impact that building the CWO infrastructure that the Action Collaborative has been making a call for the last few years has helped to absorb some of the blows. I think that's an exciting way to evaluate the impact that you've had in your role. As I mentioned, ASHP has been in lockstep with the cadence of the Action Collaborative and been focusing all of our efforts on really calling for that systems approach to address burnout and mitigate burnout and promote well-being and resilience. And so that's where our efforts have been aimed for the last number of years. And we were so excited when a year ago we saw the release of the highly anticipated consensus study that was talking about a systems approach to professional well-being. We hosted an interprofessional collaborative within weeks of the release of that report, which many of you contributed to start talking about meaningful steps and solutions that our members and physicians and nurses have been calling for. Is okay, now what? And then COVID happened and we pivoted, and the immediate needs of our members were very similar to what was pointed out during session 2 yesterday, and also what has been discussed on our panel today. The trauma involved with caring for critically ill patients, the risk of exposure, the potential to be redeployed to a new role, risk of furlough. All of those were things that our members were experiencing. And then it caused us to refocus our priorities to help advocate for their access to PPE. Big issue early on in the pandemic, securing up those supply chain vulnerabilities for those medications that were being used for patients that required intubation and mechanical ventilation. We talked about the CARES Act earlier. I'm really pleased that some of the medication shortages were included in that legislation that was passed. And And so those are some of our immediate actions. And then from a well-being and resilience standpoint, my colleague on this action collaborative, Dr. Christina Martin, and I realized that because we've been so focused on the systems approach, we needed to be really intentional to address the individual needs in the midst of a crisis, with more of an emphasis on the trauma support. And so, as Dr. Sinski mentioned yesterday, similar to AMA, we sought the expertise of military help to help with those 4 phases that are experienced during a disaster. We help from the Schwartz Center and UPMC Eastern Psychiatric Hospital to talk about critical incident stress management and trying to offer education and programming for those things. So just like you, I think it's really important for us to pivot back and make sure that we're staying focused on those long-term goals and objectives with this action collaborative. And again, look forward to continuing the path and the conversation with our colleagues in this effort.
Yeah, thank you, Ann, and thank you for highlighting the pivot that so many of us, that seems to be the word of the day, and I think also, it's speaking to what I can sometimes refer to how well-being can be everything. There's individual level, there's systems level, there's societal level. It can perhaps feel overwhelming, but I think what you speak to, what Bryant has spoken to, is that it's about understanding where the needs are at a given time, and perhaps adapting and shifting your efforts as perhaps priorities and needs change. So it's not these are mutually exclusive levels of commitment, but that we need to be adaptable. So thank you. So Pam, your thoughts, can you share perhaps an example of how in your leadership role you were able to leverage your position to develop support for your constituents in the midst of crisis?
Thanks, Jonathan. Yeah, I'll actually respond in a couple different ways. So first, locally, our medical center had put together a well-being task force. Now, what's interesting is we've actually had a long-standing set of programs that we're actually rebranding as wisdom and well-being, not just well-being. And that's a longer story than we have time for, but it takes into account all of the components such as peer-to-peer support and aspects of psychiatric care and many different counseling options, as well as many individually directed self-care programs. But as part of all of that, I became the executive sponsor to the health system leadership team. So in that respect, I've been able to really leverage resources, make sure that there is coordination among many of these groups, and that we are sourcing information from our front lines about what's happening. The second part of that is that our School of Nursing actually embarked about 3 or 4 years ago on an extensive journey to really amp up our education as well as practices in compassionate care. And it started over a decade ago, but really has been a system approach to making sure that nurses, our staff members, our faculty, everybody across the medical center, and even community members have been able to take part, particularly in mindfulness-based stress reduction activities. So it was already in place. There was a pivot, a really fast pivot for those activities to go virtual as well. And some of them we were actually able to help with some patient-facing activities, but primarily focused on making sure that all of the array of supports for staff were in place. So locally, that was happening. The other thing is we were able to really increase our moral distress service consults. Those are run by nurses, and it is particularly nurses who identify those needs, and they continue because staffing is a problem. Some of the other major issues that are stress producers, particularly for the nursing workforce. And so as we are able to bring those issues to light and be able to get significant attention on resolving those, I mean, that's been an important part of what I do. As another issue specifically to us at the University of Virginia, as I think many will know, Lorna Breen's sister and brother-in-law are my friends and colleagues at UVA. And so being able to support them and continue to advance their work, participate in some of the national recognition activities, and spreading the word about how important it is to reduce stigma, how important it is to address some of these inconsistencies in the fact that we want people to get help, but then the licensing boards have not all become temporary in terms of reducing the impact of having that information. So at the same time, we continue to be very vocal in terms of those national efforts. In my role internationally, it's been a very different focus because many other countries have experienced much more extreme restrictions in terms of their supply chain and availability of personal protective equipment, as the United States experienced really, really early on. And particularly, we know that was a big issue in New York City. So really putting pressure on countries and being very consistent in working with the media to call out the inadequacies and why so many nurses were getting sick early on, and trying to get countries to report the number of illnesses and deaths of nurses and other healthcare providers. So for me, it's really been kind of looking at the variety of places and levels of influence that we can have, but most importantly, to make sure that at that local level in the organization, that we are bringing together the emphasis of the support from the top leadership levels to act on the data that we have about our workforce.
Well, thank you, Pam. What a remarkable description of acting at so many different levels. From individuals all the way to international scope. So I thank you all for your comments. I'm going to actually pass it back to you, Pam. I know that there's other questions, but I also want to be mindful of time. Make sure we hear from Anna. But I'll let you make the call on that.
Okay, thanks, Jonathan. So I'm going to ask staff to please put up our next polling question. We'll give you a little bit more time to answer this one because we want you to be able to read through all of the options for response. So this is asking you, what can a chief wellness officer or system wellness leader do to best help promote well-being during crisis? So you have 5 choices of interventions. We'll give you another few seconds. Okay, I hope you've put your answer in, and so if we could have the results, please.
Looks like we're giving folks just another few seconds, I'm told.
Okay.
Bit wordy, that question.
Yeah, five very good answers though. All right, so you can still put your answer in, I believe. Give you a little bit, just a teeny bit more time. So staff, if you think we've gotten enough response. All right, so communication takes the top spot here. Jonathan, give us your reaction to that.
I'm very pleased to see that because it sort of validates what certainly our thinking has been here. And speaking to Bryant's experience, we've in rapid order been trying to address the crisis and get feedback on whether what it is we're doing makes sense. So it's I think validating and also I think just recognizes and may even speak to really what I think what we're experiencing right now, right? That now more than ever, uncertainty is playing a huge role. So it's the ability. I personally have been enormously struck by the ability to unload stress by virtue of answering some of the questions that remain.
Okay, thank you. All right, we're going to move on, and Anna Dopp is going to now talk with us about inter and interprofessional considerations for clinician well-being. Anna.
Thank you, Pam. So now as we transition, we talked about going from macro down to micro level. And so as we transition and talk about what are the interprofessional within disciplines and across disciplines and intraprofessional dynamics that we can harness in order to empower collaboration across our disciplines, while still acknowledging that there are unique stressors within disciplines that we need to be mindful of and to consider perhaps separately. On the next slide, I'll just share very briefly the outline. I'll talk very briefly about our commitment to well-being and resilience. I've been able to do that over the last couple panel discussions, so we appreciate that. Talk about how healthcare teams are complex adaptive systems and how we can apply some change thinking, some systems thinking towards that. And then lastly, hear from panelists about some considerations for inter and interprofessional approaches. On the next slide, I'll share very briefly, ASHP, we are a membership organization. We represent pharmacists, pharmacy residents, student pharmacists, and pharmacy technicians that work alongside you in hospitals and health systems in those acute and ambulatory care settings. Our vision is that medication use will be optimal, safe, and effective for all people all the time. And when we're in the office, this is where we reside in Bethesda, Maryland. On the next slide, we have heard from you. The body of knowledge is not as robust in pharmacy as it is in medicine and nursing, but I'll just share, it's very similar. And Dr. Brian Sexton's work in Duke has verified this, that the rates of emotional exhaustion within pharmacy are very similar to that of medicine and nursing. And so I'll skip past this slide and the next slide just to verify that we have done some surveying to identify prevalence, but our members are really now excited and wanting to learn more about some solutions. So on the next slide, you'll see that we very quickly absorbed this as a value. I hope that I can say that. Within our strategic plan, we created a goal that's falls in the pillar of our patients and their care. We firmly believe in the evidence that links that there's a risk of patient safety within the context of professional burnout. When we speak to this issue as members, we talk about it from a patient safety lens, really from three lenses. One of them is, of course, patient safety. The other is wanting for the pharmacy workforce to be empowered and thriving. And then third, to accept responsibility and accountability to help shoulder the burden across for the colleagues that they're working with on their interprofessional teams. And so that really has been our threefold commitment to this. On the next slide, I want to point out that we have a policy position that we identified developed a couple of years ago, and I'll just reinforce to a comment that John made earlier of this dynamic between the individual and the system is on one of the clauses on our position statement is that we declare that healthcare workforce and well-being and resilience requires shared responsibility among the healthcare team members between individuals and the organizations in which they work. So we tried to take the learning from this effort to acknowledge that there is this shared responsibility. On the next slide, we've developed some resources for members to try to access this information. On the next slide, you can see we developed also an infographic to try to enable them to have an elevator speech within their organizations to try to start the conversation. Just starting the conversation brings a lot of peace of mind, we've learned. And so trying to give them and arm them with that information to talk about those individual and external factors that are impacting well-being and resilience. Then shifting into the next slide, then we've also tried to provide some support related to COVID-19, again drawing on resources from the NAM as well. Then now moving into the portion of this panel discussion is on the next slide is changing to talk about complex adaptive systems. And these call on us to focus on the relations and the interconnections of all the system components rather than the individual components within themselves. And so on the next slide, very high level, to talk about healthcare teams as complex adaptive systems and thinking about those interactions and those relationships and how they simultaneously affect, but then are also impacted and shaped by the system. And so the various principles of complex adaptive systems is that they focus on patterns and interrelationships, not necessarily just cause and effect. There's random interaction that leads to patterns that change the system. They're constantly evolving, they're connected, they're nested within other systems. They're governed by simple principles. We can keep this simple as we can. We don't have to be perfect. And then they're self-organized, but on the edge of chaos, which I think is probably how a lot of us feel right now. And in the next slide, this was acknowledged by the consensus committee as they began to evaluate the framework for a systems approach. On the next slide, you'll see that they acknowledged this in their report, where they talked about the concept of complex adaptive systems, emphasized the need for organizations to establish learning mechanisms as part of change management. So on the next slide, if we think about this from an interprofessional lens, I want to go back to, on the next slide, just point out that on one of the surveys we've done, and the very last bullet point on this slide is to say that we've asked our members about their involvement on interprofessional teams, and you can see this is really pleasing to see, but a large majority of them feel valued by their colleagues, particularly by their physician and their nurse colleagues. And then the next slide, it talks about this a little bit more, that they are involved in interprofessional care teams. They feel that they've been working on high-performing team qualities. There's been work from the National Academies led by Dr. Daisy Smith and Dr. Krasinski talking about optimizing the healthcare team to prevent burnout. And so they feel that they work on teams where there's clear roles, shared goals, mutual trust, and measurable outcomes. They feel that they're working at their highest potential and they have those meaningful interactions. And so on the next slide, I think that there are opportunities to highlight where we can leverage these strengths. This is one study that's been done. There's a lot more that need to be done, but this was published in the Journal of the American Board of Family Medicine that talked about the role of clinical pharmacists in a primary care setting. And the primary care providers felt that the services provided by the pharmacists did help with some of their work life, with integrating their work life and trying to reach that balance. So with that, on the next slide, I have the questions for our panelists. Love to hear general reactions, but then what are those factors that impact burnout that are unique to your profession and your specialty that should be addressed separately with your experience? And then where are those shared threats to well-being and resilience that we can work to identify solutions across professions, and where we can look at this with an interprofessional approach. So I'm going to turn first to John, based on your role with CWO. I'd love to hear about what your reactions are to these questions.
Sure. Thank you, Anna. Thanks for that wonderful presentation. I guess looking, it's interesting. I'll answer it as a physician. I'll answer that second question from the standpoint of my own profession. But think of it through the lens of the chief wellness officer, who and again, as I mentioned before, each chief wellness officer is a little different in terms of their purview. But speaking about physicians, there's clearly some unique elements of the profession. I think, and I'm going to state this, recognizing that it also overlaps with others. But clearly there are some burdens, largely clerical, which fall upon the physician oftentimes as it relates to the mechanism by which the healthcare financial structure functions, leading to billing. And so clearly, in my view, there are some drivers that are related to the kind of day-to-day functioning of the physician, whether it's documentation, whether it's meeting a variety of metrics, whether it's just taking care of other administrative roles that are pushing the balance towards a larger amount of meaningless work and a smaller amount of meaningful work. And so if the goal is to enhance meaning in work, because we recognize that it's linked to so many important outcomes, then particularly for the physicians, I think we need to focus on that particular area.
Thank you. And then I'd like to hear from Pam from the nursing perspective.
You're muted, Pam.
Sorry. Thank you, Anna, for a great introduction to these issues. I think the first question, that there are certainly unique differences in terms of the workflow and the stressors in the work environment for the vast majority of nurses compared to physicians, pharmacists, other healthcare workers. And I would go back to something I mentioned earlier, which is moral distress is probably at this particular time one of the greatest burdens. And again, it has been exacerbated not either by volume of patients or just as we've seen, as organizations have sort of come back, brought their business back, there's staffing shortages. And when you can't provide the care that you want to provide, it creates an ethical dilemma and again, stressors that are difficult to alleviate. And so burnout and moral distress have been a part of what nursing has looked at and studied for at least a couple decades. Exacerbation of recognition of the epidemic of burnout, particularly in the last 5 or so years, where there's been much more identification across the disciplines, where yes, electronic health records have changed everyone's life and not always in a positive way. So we've seen again that interruption of how much time is being spent, what is not being done, omissions of care because documentation is taking a priority, pushing work onto other individuals as opposed to shared work is again very, very stressful. So from that perspective, again, I think we all need to continue to find the balance in terms of how can we make sure that our workforce and the workload and the workflow are really being addressed. So I think some of those represent those shared threats to well-being and resilience. But as we've also heard, teamwork is probably one of the most important things that we can focus on. And it does go back to how an organization values well-being and values the ability for individuals to support each other, to have an additional value set where communication is important, respect is important, being able to come together and address issues of when decisions are made about what a patient needs or what's the right thing to do for a patient. So I think those kinds of things are really important when we think about having meaningful work and work that does not stress people's moral decision making and the interprofessional activities.
Thank you, Sam. And Bryant, now to you to hear your experience at CWO and experience in the Midwestern area within Chicago.
Yeah, absolutely. Well, thank you, Anna. Look, I think from the standpoint of kind of what distinguishes the field, we try not to segment these factors by specialty in many ways, because I think, again, as we look to the future of healthcare, we know that we're moving increasingly to an interdisciplinary approach, to a team-based approach to care. And as such, right, one element of the team that's unwell will disproportionately impact another. I think your question's a good one, though, at least relative to physicians. Something that I think is unique is, as docs, we tend to have a hard time asking for help. And it tends to be a really tough place for physicians, and maybe the stigma and the perception of the physician leader as help seeking being a sign of weakness. And I think that's something that all of us have to continue to work towards to address and to ultimately change. In your second question about some of the shared threats, I think there's a really simple one that's certainly important for healthcare, but not unique to healthcare, and that's that we live in an always-on culture. And one of the common themes that we heard from folks as we rounded on them during the peak of the surge, and certainly as we prepare to do that once again, is this idea that they can't shut their brains off, that they're always on. And some of that is a direct result of this information era that we live in. The other is maybe a heightened sense of anxiety as a result of all the things we've discussed. But I certainly think that cultural piece is something that is a shared threat to our well-being.
Thank you. Thank you for all these really important comments.
Anna, if I may, I want to just speak to, because you asked a few questions there. And so I think I answered the second, but not the third. And I do just want to, listening to the other panelists, I just want to highlight that, while there are, I believe, drivers that impact well-being that are specific to a discipline, and quite frankly, within physicians, there are very different drivers that are impacting, say, procedural, surgeon, those in procedural specialties and those in ambulatory specialties and so forth. So even within a discipline, there's a lot of variability, I think, and a need for an individualized approach to enable those professionals to get the job done. The work itself has meaning associated with it. If we are enabled to do it in a way that's efficient, then we're likely to derive greater meaning from it. So that's critically important, I believe. You got to pay attention to those specifics, and yet, what's overarching as it relates to really crossing disciplines is the culture of the workplace, right? And this again speaks to is well-being a value? If you work in a workplace where you feel like your well-being is valued and that it's a priority of the institution, you can withstand a lot of stressors because you feel like someone's got your back. And so I think that is a critical way of thinking about sort of a cross-professional approach to promoting well-being on a large scale.
All right, Manna, should we move on to your polling question?
If there's time, it would be nice.
Yeah, let's go ahead and do the polling question. Next polling question.
I'll maybe just give some context to this question, because when we do talk to our members and we find out where they are in their journey towards addressing well-being and resilience, we've asked, are there interventions being made? Are they at the individual level? Are they at the system level? Are they targeted within your department? Or are they across your organization? And it's interesting to see their responses. And I think this is a little bit of a shorter one, so if we can display the results more quickly, then we'll make sure we have time for this last part of our discussion. Okay. Consistent with what we've seen as well. And I think the part that we hear is that if those across disciplines is just make sure that there are those voices from each one to make sure that you're informing the work and you can find those shared opportunities for collaboration.
Great, thank you. All right, so I just want to round out our discussion topics by talking about the overall need for culture change. I think it's inherent as we've listened to the different presentations where we started out hearing from Bryant about the need for wellness and well-being to be a value. And that's really the starting point as we think about culture change and recognizing that whether you're starting looking at this as a ecological systems model where we need to understand the relationship of the individual to the community and society, and then recognize that there is also at play this complex adaptive systems model that is going on at the micro level. I think it again reinforces the fact that relationships are important and that we need to be looking at the pattern of activity within our organizations. But we also know that, and something that's been said numerous times, is that it really is very dependent on leadership. If we don't have leadership at the top that says, our culture needs to support an appropriate set of values, and with wellness being one of those values, then it's going to be very difficult to bring together the resources that are needed and to have all the individuals across the system believe that this is being taken seriously. We've been very fortunate to have very significant guidance from the consensus study. And again, the recommendations really begin with building that culture of values and recognizing that we have to have values that dictate what we do for our workforce and how we treat one another. And whether or not those can be imposed versus they need to be built and nurtured is a question within our organizations. But the culture needs to support not only change management, a set of values, but also the psychological safety and peer support that we know is really important when we think about having a well-being system. Now, some of the other things that are pointed out in the consensus recommendations that have been touched on here and that we know are some of these drivers of burnout have been the work system. And redesign of that work system is something that we know has been critical. And I think there's a little bit of a tug and pull between what do we focus on first? Do we focus on helping individuals who are expressing a need for resilience activities or well-being, or do we focus on all of these external factors that we know have created a sense of frustration, lack of control, lack of power, and burnout? And the answer is really we have to do both. But it really does start with making sure that we are focusing on the culture change that's needed. That includes optimizing teamwork. It includes what some of the things Jonathan talked about, making sure we're identifying our sources of stress in the organization where we are, as well as these other macro factors that Bryant has talked about. What are the strategies that we're putting in place? Are they both for the organization and for the individual? And making sure that we're addressing the leadership skills that are needed to make sure we're able to continue to redesign our systems and make sure that they are, again, meeting the needs of individuals. So I want to focus a little bit more on some of the other questions that have come into the panel in the time that we have left. And recognizing, too, that one of the things we've de-emphasized is the fact that most systems do have a lot of self-care and self-help interventions, and we've purposely stayed away from that today because you can get those kinds of support systems from many sources, and we see that as sort of the very basic aspect of what an organization has. But it's without the leadership commitment, without the establishment of culture, without being able to live that culture and make sure that it is visible and reinforced in our organization, we know that all the self care in the world isn't going to help get us out of the crisis that we're in. So one of the questions that was asked by our audience was, we live in a system that's small, that doesn't have all these resources, would love to have the kinds of role like Jonathan described as his chief wellness officer role, and some of the things that Bryant described as well. But how would you advise on a starting point for an organization that just doesn't have the resources but seems to be ready to make the step into creating a wellness program and system? So either to Jonathan maybe to start, and then maybe on to Bryant for that question.
Yeah, thank you for that. And I will say that is a common question that's asked. This idea. Well, it's great that you have a chief wellness officer at your HealthSystem, but there's just not the opportunity for that. There's either not the buy-in, there's not the resources. And the way I always answer that one is, having a chief wellness officer is not going to solve this problem. If you have a chief wellness officer that is not enabled to do the job as I described it on the first slide of my talk, then you're just checking a box that's actually just window dressing. It's not going to do anything. So it's not so much that you need to, wherever you are, whatever the size of your organization is, that you have to be thinking, okay, how do I get to that? How do I get that chief wellness officer now? It's more about understanding, diagnosing where your system is at, where your hospital is at, where your practice is at, along kind of a continuum of commitment to well-being. Getting to that point where it becomes, it's part of the culture, it's in the soil, it's a strategic priority of the organization, however big or small. And that's a process. I tell people that who wonder how does one become a chief wellness officer. In fact, I remember Daryl Kirch, who may not remember this, but who was a co-chair of this group, that we were giving a talk once, and he said, well, maybe you can be like John and get on the chief wellness officer track, speaking to an audience of students and residents. And I remember thinking, I don't remember what that track was to me. I've had a very circuitous journey to get to where it is. It took 15 years, starting out on a very small scope, and gradually rising. So it's not about tomorrow you got to have the full spectrum of offerings. It's about understanding where you're at and moving forward along that continuum.
Thanks, Jonathan. Bryant, let me pose a question for you. To what extent has wellness as a value been infused into curricular objectives, specifically perhaps even the July boot camps by some of the organizations like ACGME and then CPRs and the Claire for residents? How do you see this being brought in internally for trainees?
Yes, I think that's a really good question. And I think if I'm frank, I would say it hasn't been as clearly articulated and well developed as it should be. And that was part of, I think, my goal with our presentation today, was to really reframe this concept from thinking of wellness as an issue and reframing it really as a core value. And I think once we do that, we will start to really penetrate to levels much more deeply. So I would say it probably hasn't been done just as much yet as we'd like to see, but I think there are some opportunities to do that. I mentioned some examples of what we've done here at Rush. So having those important conversations around mental health and otherwise, we put a special emphasis to kind of answer this audience member's question on GME. So instead of just hosting these dialogues from the wellness office or from physician leadership standpoint, we actually had residents co-lead these conversations and ensure that we address the topics that were important to them. We also have a number of tools that we roll out for our program directors and for incoming house staff so that as they begin their journey here at Rush, there are really clearly delineated pathways for supporting their well-being.
Thank you. Anna, let me send a question your way. And this is about team resilience. Are there other specific strategies beyond what we might know as some of the formal training programs that you've used or are aware of in terms of building team resilience?
Well, I'm definitely not an expert in that as a pharmacist or for that question, but we've had a lot of reflections over the last 2 days about linking, and we have for years, about linking the efforts of the Action Collaborative to the 1999 to Air is Human landmark report from the Institute of Medicine, now National Academy of Medicine. And I think there's some benefit over the last 20 years that we've been building capacity and expertise within our health systems to call for that culture of change. And so we can take the mechanics from that to perform these process improvements and implementation science to carry forward some of these things. So I think that, that's a real example where teams have been applied, is looking, for example, at medication safety, and medication safety was highlighted into the To Err is Human report. And within that, then there was a call to make sure that we're performing those risk assessments. What are the issues at the local level? We know that burnout is a local issue, requires local solutions. So as a team, as they work through other performance improvement initiatives, can't we apply some of these same principles of performance improvement to well-being and resilience, where you're routinely conducting risk assessments, where you're applying those change management and implementation science principles to address those risks and then continuously monitor? I think it's a good example of where teams have already been together and working on problem solving.
Okay, so this question is for all of you. What advice would you offer to a team or staff who have come together and they want to create or have created their own wellness committee, but they're not getting support from their local and higher level leaders or human resources or anybody? So we've got the group that wants to act on this, but they can't get support. How would you advise them?
I'll take that one, Pam, at least to start off. Listen, I think, and there was some other questions about kind of scope, and to follow up on that question of whether you have a chief wellness officer or not. One of the key findings of the consensus report that the NAM put out and that a number of studies have found is, executive level leadership is really key to driving wellness forward. But there's two ways that you can go about doing that. So in some institutions, you have the benefit of having a chief wellness officer that can really help drive that from the institutional standpoint. The other approach, though, is to really build a swell of culture from the bottom up. And many would argue that latter approach is equally, if not even more, impactful. Now, we know that culture change takes time, and we know that some of those really grassroots level changes may be very challenging. But what I would recommend in this circumstance, Pam, for the group you've identified, is work with what you can. So if your higher ups have not necessarily provided either the funding or other scope of resources, work within the confines of what you have. Wellness can be very simple. Work within the teams, support the clinicians in your department. If you don't have the scope of the department, support the person who sits next to you, and begin to build that cultural change from the bottom up. And what that will do is it'll begin to shift the organization really on a very deeply personal way, such that leadership and others will be able to see that reflection and ultimately formalize and incorporate it.
So great advice. You're saying it's contagious, that the success will spread. Okay. Well, maybe we'll move on to another question. Jonathan, this one specifically for you, and it goes back to a theme that has been addressed by our previous panel. And that once again comes back to the physician licensing and the reporting of any kind of mental health treatment. Have you been able to orchestrate anything specific, either particularly in your role in your organization, or as you are networked with chief wellness officers around the country? Are you able to see a trend to be able to shelter some of this information? And obviously we know that you have to follow laws and things like that, but can you be more specific about the maybe, again, the advances that we are making to make this reality?
I want to make sure I understand the question. Is it about moving in a direction where the questions that might stigmatize and limit help-seeking behavior on the licensure applications, moving in a direction to where there's change on that?
Yes, and any reporting that people feel that has to be done now.
Yeah. I mean, I think our earlier speaker from FSMB referenced it, I believe. But this kind of groundswell movement around this, as I understand it, has through advocacy work has led to a number of states changing the language. So I think we're actually seeing that in action. And we're seeing the role. I loved what Dr. Moutier said about the heart and the mind. It's first, it's studies like those of Dr. Derby and others who showed that these questions that physicians indicate that they're less likely to seek help when you see that these questions are on the applications, and that's the knowledge, that's the mind, and then there's the personal stories of people that are suffering, who are suffering alone, who are not seeking help when they need it. And so taking that and advocating, I'm heartened to see that there's been a definite positive benefit as a result.
Okay, great. So another general question, how do you recommend that teams that are already pretty fatigued right now, feeling overworked and overburdened, how do you think teams should really respond in terms of adding wellness and resiliency training to what they're already feeling as a very full day or week?
I'm happy to take that one and share with the panel as well. Pam, part of how we've approached that is, and we certainly understand that level of exhaustion and fatigue as this pandemic continues to rage on. But part of what we've done is by placing an emphasis on on-demand, mobile, accessible training tools. So recognizing that everybody has schedules that may vary and folks may have different times in which they would want to approach their wellness. Part of our emphasis has been really on tools that folks can do on their phones, that they can do from home, that they can do during their commute, and other times that are really amenable to them, moving away from a traditional set schedule. So I certainly advocate for that. And we found a lot of success, particularly amongst our nursing staff, with kind of enforcing that flexibility.
Yeah, I'd add one more. So this is a huge challenge, by the way, because if the wellness activity is seen as one more thing I've got to do in the day in order to stay well, it can actually backfire because it's just adding another piece of another load, another burden on the day. So another way in which this can be done is actually replacing some sort of regularly scheduled activity with the wellness activity, literally integrating it into the day. So if you have leadership meetings, if you have huddles, if you have grand rounds that are happening already, just swap them out with a structured well-being or resilience curriculum and use that time.
Great. Anna, anything you'd like to add?
No, I defer to the expertise of Bryant and John for sure, but I do want to just, we talk about advocacy and we talk about it with a big A and a little a. We've kind of covered both. The big A are thinking about regulations and legislative changes, and then there's a little a, which is the grassroots and the groundswell, and both of them need to be empowered, and both of them have the promise of a lot of impact. So not to diminish either one, we need both.
Thanks. I think the only other thing I would add is not so much around training, but one of the things that is used in suicide prevention is just the simple act of asking, how are you? I think this was mentioned earlier on, but it's very interesting as people are now recognizing that with less peer-to-peer contact, with so much of our world being virtual, asking that friend, colleague, family member, whoever, how are you, can actually open a floodgate of sharing true feelings. And sometimes it is that peer-to-peer, friend to friend, that can be most influential in making sure that people get help. So I think that's a really simple thing that we all need to say, yeah, maybe we've got that few minutes to be able to ask that question and take it from there.
Pam, can
Okay.
I add just one piece to this great
Sure.
question about exhaustion, something that I think had come to mind with the great point that you made. Many of us are health system leaders, and we oversee teams or support a community or take care of institutions. And as we continue on into what will likely be a second surge in this pandemic, I just wanted to, add at least some commentary or some suggestion that we also look out for leader exhaustion. And as much as we're caring for others and taking care of other folks, it's so important that we also have opportunities for self-renewal, for self-care, and to take care of ourselves so that we can continue to lead and support the well-being for these institutions. But it really does take, I think, giving ourselves permission to rest and recover. It's the only way we'll be able to continue to be effective.
Great point. Absolutely.
Pam, can
Okay.
I take a moment to echo and amplify Bryant's comments? And this was mentioned yesterday by Dr. Farley as well. I have been talking to some leaders in our health system, and what's emerged is that the people that we're really seeing who may be experiencing this exhaustion to the greatest extent are the leaders. And we're talking about there's leaders at multiple levels, but hearing anecdotes about people in positions who haven't taken a day off since this began in March, it's really it's worrisome. And I think actually we all need to recognize the phase of this crisis that we're in. We're in that post-acute disillusionment phase where exhaustion is taking its toll. We need to ask that question that you asked, Pam. We need to say, hey, how are you doing? And we need to ask that of our leaders. Have you figured out how to take some time so you can rest and recharge? It's critically important that we recognize that's where we are in the here and now.
Thank you. Well, let's do our last polling question because it might pull together some of these thoughts. And so if staff would please put up the last polling question. And we'll again give you a little bit more time since the responses are a little bit wordy, but asking you to prioritize what would bring the greatest impact in your organization for a system level change. Okay, does it look like we've got sufficient responses? Okay, so again, I think probably not surprising, visible, meaningful leadership, which we know is absolutely a key ingredient to helping establish and implement the value system. All right. Well, let me thank all of our panelists, and I know many questions came in on the Q&A, and I want to just ask staff, we had a question, will the slides be distributed, and then also will there be any opportunity for responses to any of the questions? I don't know those logistics. But if you could address that at some point as the meeting closes out. But I do want to thank all the panel members. Again, hopefully we've been able to provide more insights about taking action based on best practices, based on evidence, based on recognizing that there's never a one size fits all, and that there are many complex issues that putting together a system response to wellness and well-being is really critical. So thanks, everybody.